Welcome to this second symposium, and it's focusing on pediatric kidney transplantation. So for the first speaker, I would like to invite Professor Lars Pape to come up to talk about chronic humoral rejection.
Yeah, thank you very much for the kind introduction. So I have two talks in this session, so hopefully it doesn't become too much for you. In the second one, I've put some cases in chronic humoral rejection. It's a little bit difficult because the field is just changing. So I've just written here chronic antibody-mediated rejection in red because the terminology has a bit changed, and primarily in the very actual literature, people are more speaking about chronic AMR instead of chronic humoral rejection. And why do we speak about that? Because you can see that antibody-mediated rejection is in long-term graft survival now the most important factor leading to most graft losses. And especially, we've heard this fantastic talk from Rupesh Rana about transition. This happens because also of non-adherence in the transition period. So like 20 years ago, we called all of that chronic allograft nephropathy because we didn't really know what was happening. And we've now got aware that chronic antibody-mediated rejection is the main cause of that. And this is data from our European certain registry. And what you can see is that we have both with acute AMR and chronic ABMR. But if you look at the outcome, you see that only a chronic ABMR really leads to a lot of number of graft losses, whereas acute ABMR, mainly happening in the first days or weeks after transplantation, can most often be treated quite properly. So this is a kind of slide that summarizes my whole talk, and I'll show it later on again. It's from a very new publication from Georg Böhmig from Austria, and I think he's Mr. Chronic CABMR worldwide. And here you can see both pathophysiology and treatment within one slide. And if you go into the lower part of your slide, you can see the three problems. We have plasma cells that produce antibodies, and these antibodies lead to complement activation and thereby cellular stress. They lead to intracellular cellular signaling, and they lead indirectly by NK cells to cellular activation. And you can also see that this is a long process, starting with T cells activating B cells, then memory B cells that became plasma cells, and then these plasma cell NK cell interaction. And at all these stages, they are possible or there are possibilities where you can interact, where you can do an anti-B cell therapy, where you can work against memory B cells, where you can use proteasome inhibitors to work against plasma cells, where you can use antibodies that work against plasma and NK cells. You can try to stop the complement cascade. You can remove antibodies. So there's more or less a lot, at least theoretically, what you can do to avoid antibody-mediated rejection. So how do we diagnose that? And traditionally, what we do is creatinine is slowly increasing. We do a graft biopsy. In parallel, we look for donor-specific antibodies. And if you have a living donor, we can also do a virtual or a classical cross-match. If it's available, you can also look, for example, for a cell-free DNA as an early marker of graft damage. Many centers now also regularly do assessment of donor-specific antibodies, and if they become positive or go over a certain level, then they perform a kidney biopsy. So the first thing, and we have heard plenary talk about that in the morning, is that you have to look for a good HLA match, especially a good match for HLA-DR and HLA-DQ, and that can really avoid future development of donor-specific antibodies, and if you have the abilities, you can even do an epitope matching. So prophylaxis in that case is quite important. Do not transplant if you have a complete DR and DQ mismatch. If you have donor-specific antibodies, many of these donor-specific antibodies just resolve. So having donor-specific antibodies does not mean you really will develop chronic antibody-mediated rejection. As you can see here, as earlier of those antibodies evolve, as more of them resolve, there's no really age difference. You can see those with a low mean fluorescence intensity tend to resolve more often than those with a high MFI, and you can also see if the peak MFI is very high, then they also tend not to resolve. So you should measure these donor-specific antibodies, look for MFI, look for the time after transplant, and after several measurements of those donor-specific antibodies, you can decide, also depending on proteinuria, on kidney function, if you do a kidney biopsy to prove that you have chronic antibody-mediated rejection. And they're not only HLH antibodies, you can see here that also non-HLA antibodies against endothelial targets can cause chronic humoral rejection. This is not the focus of this talk, but especially in patients where we have antibody-mediated rejection in a biopsy but do not find HLA antibodies, also look for non-HLH antibodies. Actually, it's not a routine thing to monitor like AT2 antibodies or MICA antibodies, but in special cases that might also be an important thing. And if you have those antibodies positive over long term, your risk of graft loss is also increasing. So going back to donor-specific antibodies, there's a big difference if you have a pre-existing DSAs or if you have de novo DSAs. And you can see that the probability of graft loss is much higher in de novo DSAs. So you need to know at time of transplant if there are DSAs, and you really have to look whether the DSAs you detect are de novo antibodies. And another option to look whether these antibodies will really do harm is to look if these donor-specific antibodies are complement binding. And if you have complement binding DSAs, then there's additional factor that reduces your graft survival. So obviously not everybody has all of these assays available, but I think at least it's important to know that you have to regularly look for DSAs, that de novo DSAs are the bigger problem, and especially de novo DSAs that are complement binding. So just coming back to this figure we saw in the beginning, now it's really important to think about treatment. And what you can see is that there are many treatment options mentioned in the slide, but many of them are not actually available in pediatric transplantation or are not really tested in good trials. So what are options we really have? This is at least rituximab, and there's some data of that. In anti-complement therapies, we mainly have eculizumab, but at the moment there are other components in clinical studies. You will see later on that's also true for very other diseases like IgH nephropathy, but actually only eculizumab and iptacopan are available, and iptacopan is very expensive. Other components as pegcetacoplan will arise. Then we have the easy possibility to remove antibodies by plasmapheresis or maybe immunoabsorption. That's something we can do for many years. There are the first countries where imlifidase is available. I'll talk a little bit closer about these agents later on. This is an agent that destroys antibodies. And also we have for many years IVIG, that is at least altering IVIG function. The only proteasome inhibitor that is long-term there is bortezomib, but there are no good studies really proving that it works. And carfilzomib is more or less new in the market for transplantation. And we have very new, we have CD33 antibodies that work against plasma and NK cells, like feltazumab and daratumumab, but both of them are also quite expensive, and in pediatrics we only actually have case reports on that. So this is more or less the first study that we've done in our certain group that has been published around 10 years ago about using IVIG and rituximab, sabzimab for a longer time, and you can see that at least generally it stabilizes graft survival in those patients with CABMR, but you can also see that it only helps some patients and that it just stabilizes but doesn't make kidney function better. So the use of IVIG and rituximab is a way to go, but is not the whole solution of the problem. And this is a slide showing studies in adults using what you can see here: rituximab, bortezomib, tocilizumab as an IL-6 antagonist, eculizumab, and then C1 esterase inhibitor. And the conclusion of this review is that more or less none of these drugs has really shown a long-term benefit, and even theoretically these drugs should work. They do not in large adult studies. So probably all of these drugs are, at least using them alone, not the best way to go if you have de novo DSAs that lead to ABMR. So here you can see phase 2 to 4 trials that actually have just been done or are done in adults, and at least you can see that some phase 2 trials are finished, that some trials have even been prematurely terminated because they did not work well, and that some trials are just recruiting. So we are just in a very interesting process with all these trials and all these new drugs, really seeing what might be the right ones in the future to treat CAMR. And one short slide here on imlifidase. It's a very actually very expensive component that cleaves IgG. And it has been marketed for HLA incompatible kidney transplantation. So using this component you can avoid hyperacute rejection. And the idea was maybe this should work better than doing plasmapheresis, because with plasmapheresis you always just can reduce some amount of antibodies, but not all antibodies, whereas giving imlifidase after just like 2 hours, more or less all IgG in your body is cleaved and you don't have IgG. And what you can see is really that imlifidase reduces DSAs much better than plasmapheresis does. But obviously you have to take into account that with imlifidase you do not reduce further production of IgG, you just delete the IgG that's in the body. So you have to probably combine it with other agents as IVIG, as rituximab, and maybe also a proteasome inhibitor to avoid future production of IgG. But maybe in the future a combination with imlifidase, if you have antibody-mediated rejection, could become a standard. But again, it's just one component of a combination and not the only component. Then there's just a study going on clazakizumab as an IL-6 antagonist on treatment of AMR. But you've seen that the other component, tocilizumab, did not really work, so we do not really know what will happen with the study, but maybe also IL-2 and 6 inhibitors like clazakizumab will become an option. A more interesting component are CD33 antibodies, and as you have seen in the slide before, they act on plasma cells and NK cells. So you have a component that has a kind of double efficacy in chronic antibiotic rejection. So you can really, at least theoretically, produce the number of DSAs and thereby the disposition of DSAs. You can indirectly reduce thereby complement activation, and you can reduce the NK cell mediated microvascular inflammation. And these antibodies, as many of the antibodies we use in nephrology, just come from oncology. And the study for feltazamab for ABMR has been published in the New England Journal of Medicine, and it's a phase 2 study, which I think is a signal that this is probably a component that will really help us in the future. This has just been formally a study with the primary endpoint of security of that component, so it is quite secure, but there were secondary analyses, and this is data that has primarily presented last year at the ERA Congress and not yet been completely published. But what you can really see here, that if you use feltazamab, you have a really high resolution of AMR activity of 81% as compared to 20% in placebos. This is, I think, a very important sign that this component is probably working. And you can see also that at least in some of these patients, the AMR activity is not recurring. And if we look for other surrogate markers, I think you know the MMDX, the molecular AMR classifier, which comes from Van Hederen and the Edmonton team. You see that this classifier is less presented in those patients who were in the feltazamab group. And you can also see that de novo cell-free DNA, more as a general marker for destruction of the transplant kidney, is also reduced after the use of feltazamab. So, yeah, I think the phase 3 trials are now running, but feltazamab might become a very important component, and that, for example, maybe in combination with imlifidase and rituximab might make a significant difference in the future. So we don't have good treatment standards in children. I will shortly come to them. The adult actual treatment standard published this year is do causal therapy, so remove the antibodies by plasmapheresis and maybe imlifidase. Optimize your maintenance immunosuppression, look for adherence of your patients, and try to give, if you have them available, CD38 antibodies and maybe complement inhibitors for refractory early cases. And I have no time to go through that completely now, but you may just look in that publication and you can see what to do. And what is quite interesting in the adults, there's so many clinical trials running that the adult nephrologists say, first try to get your patient in a trial so we get more information, and then think about these different components. Optimize your immunosuppression. If it's early, remove DSAs. In more or less all patients, give CD38 antibodies, and maybe steroid pulses and other things might also make sense. So just at the end of my talk, going into children, we had the opportunity to do evidence-based guidelines on immunosuppression in pediatric kidney transplants that are not yet published, but more or less finished, which was funded by the German government, but there are common guidelines by CERTAN, by ERCNET, by ESPN, and also by the IPTA and the German Society. And we also looked for the evidence we have in humoral rejection in children. And you can see for diagnostics, we have for children's recommendations that at least you should periodically monitor de novo HLA-DSAs. that you should do a renal biopsy if you have persistently de novo DSAs, so not only for one measurement, that you should try to establish an uniform mean fluorescence intensity assay to measure them, that if you have the possibility, then please look for complement binding status of these DSAs. Then if you have a decline, if you just have DSAs and without a decline in renal function, then probably IVIG treatment does not really work in combination with rituximab, so a preemptive therapy to avoid CAMR does not seem to work actually. Its therapy is reserved for those patients who really have CAMR. In a biopsy, because of the study I've shown you before, we suggest to use IVIG and rituximab because at least in a part of the patients this does help. But finally, for the CD38 antibodies, where we have some adult data, we could not really give a recommendation for children, as they are just like single case reports out. But maybe in a teenager, 17 years old, non-adherent, it might make sense to use it in parallel to adults if you have at least the money and the availability of this medications. We think that proteasome inhibitors may not really be of use also because of their nephrotoxicity, and obviously you have to consider an optimization of the immunosuppression of their patients. Okay, so thank you for listening.